Many have dreams to be a medical professional. When choosing an institution for medical school, a lot of things matter. The quality of the academic and clinical programs, as well as the clinical experience. At UNIMAS, we offer that and more. A supportive culture, a vibrant community, diverse student and patient population, all set against the backdrop of Kuching and Kota Samarhan.
The culture here is welcoming. It is a big family. Everyone wants the next person to succeed together. We want our students to reflect back to the society and the community today as a community-driven university. We believe that immersing themselves and ourselves in the diversity, it creates better innovation and greater creative achievement.
In UNIMAS, there's not a culture of competition here, but a great environment is what we all strive for.
Everyone is committed to create a great environment to become a great doctor in the future.
Our patient population in Malaysia is remarkably diverse. Different languages and dialects will be something that we face every day once we become a doctor. So, getting to know this and learn it now makes us to be more appreciate and respect. It just sets us up to become a better doctor for the future.
From the beginning of the program, 25 years ago, we have adopted spiral curriculum. As the students advance forward into their years of clinical study, we connect everything back to underlying basic biological sciences. We connect and revisit every aspect of human health, from emotions to diseases, back to its basic biological sciences.
We are introduced to clinical setting early in our curriculum. The exposure gets more as we advance through the year. It was very daunting at first, as a first-year student to step into hospitals and seeing patients. But at the same time, it's really an exciting experience.
We are committed to excel in nursing education, research and practice. We view health as a complex and dynamic, and the client as a holistic individual. Students in this program learn in an environment that stimulates intellectual inquiry and creativity, which encourages them to be problem solvers and lifelong learners.
Here, we learn how to care, to serve, and to help. We went from zero to hero.
I really cannot pick a better place to learn and become a greatness. This is a place that belongs to my heart throughout my journey.
Come do research with us.
Come and join us at UNIMAS and realize your dreams.
Dayang continued her career in nursing education, joining UNIMAS in 2013. Amongst other courses, she takes a special interest in teaching gerontological nursing to our undergraduate nursing students. Our second speaker is none other than Mr. Dennis Tan, who hails from Miri and has settled in Kuching for many years. A retiree, Mr. Tan is prominently known as the founder of the Sarawak Gerontology and Geriatric Society and is still presiding over it ever since. His work in the society aims to raise awareness towards healthy aging and work towards a long-term health reform plan for aging citizens in Sarawak. Before we commence with the webinar proper, I would like to urge all participants to stay with us till the end of the session, where we will provide you a link to a feedback form to capture your details so that we can send you your electronic certificate of attendance for this session. As this is a live feed, you too can contribute to the discussions by posting your comments as well as questions for our panelists on the YouTube or Facebook page which you are currently on. Our secretariats working behind the scene will collate your comments and questions to be highlighted after our panelists have completed their sharing. Ladies and gentlemen, not wanting to take any more time away from our speakers, please allow me the pleasure of inviting Dayang Zuraina to kick off the session. Dayang Zuraina, the floor is yours.
Thank you, Dave. It's always a pleasure to work with you. Good morning, everyone watching. Welcome to our fourth Health Talk series from the Faculty of Medicine and Health Sciences, UNIMAS. This month, we will be talking about dementia. And I'm very thankful that Mr. Dennis Tan, who is also an old friend of my mother, because they were in Miri together, to be actually available with us today to talk about, older groups, older persons, and how dementia actually affects everyone. It's not only the person itself. Of course, it's very hard on the person. It is also exceptionally hard on the caretaker, and the community itself actually has very important role in supporting the person with dementia and the caretaker who is caring for the person with dementia. All right. So our talk this morning, we will go in a few sections according to the topic itself. For my part, it's a little bit more academic, it's a little bit more factual. I'll be talking about the person with dementia itself. What is dementia? What are the different types? It's a very big topic. It's actually an umbrella term of a lot of different conditions. So I'll just go as simple as possible so people can actually understand. And then we will go into how dementia is going to be managed. How do we assess dementia? Where we can intervene and where we can include the family members, the caretakers, and the community in dealing with someone with dementia. As we well know that the term dementia, if it's in local term, we hear people saying, if it's in Sarawak, we say babo. And in Bahasa Malaysia, we say nyanyo. And it's a very big term, whereby a lot of different types of dementia actually come under that term itself. So for dementia, if we look at it worldwide, now we are having around 50 million, in between 50 million to 82 million people with dementia. And it's set to triple, it's projected to triple by 2050 to be 152 million. So there are nearly 10 million new cases every year, and it's similar to 1 in every 3 seconds. And it depends on what triggers it, it depends on how bad it is, and things like that. And the majority of people who develop this are usually in low and middle income countries. Most of the time, low and middle income countries, we may have problems with, I'm not going to say problems, challenges. We may have challenges with issues of stigma, awareness, the psychosocial state of mind of caretakers and community itself. So, as we well know, for people with dementia, families and friends, they provide most of the care, because some of the times, depending on the severity of the dementia itself, as it progresses, that person with dementia will need more care from other people, and this is where the community also supports the caretaker, the family members, and the friends who are caring for someone with dementia. In Malaysia itself, we've got a foundation called the Alzheimer's Disease Foundation. They're very active, especially in West Malaysia. Since 2016, we've got around 50,000 people. That's just a round number with Alzheimer's. It's expected to be higher already. That's Alzheimer's itself. Alzheimer's is actually a very major type of dementia, very common type of dementia. For other types of dementia, we have around 125,000 people with dementia in 2015. And we expect it to double in 2030 and then to triple definitely in 2050. So this is a very big number. And when you think about, having one person with dementia itself, depending on the level of dementia, you would also think that, okay, one person means how many carers? So it's going to have this ripple effect with the carers and also with the community itself. So if you've got one person with dementia and you have at least, say, two persons caring for a patient with dementia, maybe more, then you can actually see that ripple effect whereby it affects everyone in the community as well. So, this awareness of dementia is actually very important. Like I said earlier, dementia is actually an umbrella term. There's a lot of different types of dementia under the term dementia itself. So it's basically what happens to the brain under dementia. It's whereby you've got this altered cognitive pattern. Cognitive means things that you do with your brain, the thinking skills that you have with your brain. And when you have dementia, it is very, very difficult for people with dementia to go about with their daily life. All right? It is the ability to process thought in itself. So it will affect a lot of things, memory, thinking, trying to analyze something, trying to figure out how to open a door, for example, trying to figure out their smartphone, learning capacity, language, judgment. However, consciousness is still there. It's just that those thinking processes are digressing, all right? And when these thinking processes are actually affected, sooner or later, it will also affect the emotional control, the social behavior, and the motivation of that person with dementia. So this little umbrella picture, I like this picture because I love the colors. Alzheimer's is a very, very common type of dementia, and it's a progressive disease in dementia, and it's not reversible. We've got other types, things like Lewy body dementia, vascular, frontotemporal. It all means that there's a structure of the brain that is damaged or that has lost its connection, that has that name, that's given that name. Okay? Other mixed dementia is dementia will be due to more than one cause. For example, traumatic brain injury. Someone has had a stroke. They might go into dementia if the stroke has happened in a certain part of the brain, and it affects the thinking processes of the patient itself. So dementia, like I said, it's damage to a loss of nerve cells and the connections in the brain, be it due to progressive degeneration of the brain, where we see things like Parkinson's disease. Someone has Parkinson's disease. It's a degenerative disorder of the central nervous system. And it also affects the brain, which is the big part of the central nervous system. All right? Alzheimer's disease is very common. It's a disease that attacks the brain, resulting in impact functioning, so it degenerates as well. Okay? And it depends on the area affected. So it can affect people differently and cause different symptoms. And I think this is why the community and people who live around those with dementia recognize the symptoms and the characteristics a bit late. So, a simple forgetfulness, it can actually degrade along the timeline itself. And if the community is not alert, if the caretaker, the family members are not alert, they will only realize it when it comes to a very late stage. And that will cause a lot of stress on the community and caretakers because, suddenly, boom, you have dementia. You don't eat well, you've got incontinence, you don't sleep well, you don't remember the face of your family members, and you get aggressive. So that will cause an instant stress on family members itself. And definitely ripples to the community. Alright, so progressive dementia, like I said, these are the type of dementias that they progress and they are not reversible. And the very common one is Alzheimer's. I think we've heard a lot of people talking about Alzheimer's itself. Other disorders that are linked to dementia with things like, quite rare, Huntington's disease, Creutzfeldt-Jakob disease, Parkinson's disease. These are diseases that affect the connection of the brain cells or the brain structures. And traumatic brain injury, like strokes, which we usually also see a lot in older age group where they have hypertension, where they have heart problems. If the heart is not pumping well, there will be blood clots in the heart and it travels up to the brain and causes a clot in the brain, which causes a stroke. Things like that. So traumatic brain injury or simple brain injury due to vehicle accidents, falls, and things like that, it can actually be linked to dementia. But it's not dementia, it's sort of like a secondary dementia. Other dementia-like conditions, now this is also something that we need to highlight as well, because sometimes certain conditions look like dementia, but it can be reversed or treated. So I'm just going to compare it so that we can understand. So when you've got someone with cognitive skills problems around you, you might want to look into whether it's dementia or it's something that's dementia-like, and you can reverse it. So infections and immune disorders, problems, metabolic and endocrine problems, deficiencies with nutrition, side effects of certain medications. As we well know, older age people with multiple diseases like diabetes, chronic kidney disease, heart failure, obstructive lung disease, especially for those who have been smoking for many years. All these conditions are very common in older age groups. And when they've got all these conditions, it comes as a multi-condition whereby, if someone has diabetes, they can also have hypertension, they can also have chronic kidney disease, things like that. And they have what we call polypharmacy. Polypharmacy means they are being prescribed a lot of different types of medications, one for diabetes, or maybe two if the diabetes is not well controlled. Few medications for their kidney disease, something for their high blood pressure, things like that. Some vitamins or supplements, things like that. So medication side effects, if not being organized well, it may actually cause dementia-like conditions, depending on the type of conditions that they have, the type of medication that they have. So this is very important to me personally. I usually teach polypharmacy in older age group. This is very important for those out there who are caring for older people to keep track of their family members' medications and side effects, so you can actually adjust and look into it and prevent dementia-like conditions. Brain injuries, poisoning, brain tumors, hypoxic brain means where someone who has not enough oxygen to the brain can actually cause dementia-like conditions. Right? And hydrocephalus will be there's lots of fluids in the brain itself. So some connections may be disconnected there. Risk factors for those who are at very high risk for dementia. We've got a couple of Sorry, it's actually the other way around. Unmodifiable would be your age, their family history, and Down syndrome itself. So this type of patients, we can't actually modify, your age because you're aging. You can't modify the family history. If you've got someone with dementia and a family history, it means that you're at a higher risk of getting dementia at a certain age. And those with Down syndrome, because of their conditions itself, we know that brain degeneration usually happens quite fast as well. All right. For those with modifiable factors, these are the things that we can adjust and we can modify to go into a healthy lifestyle and reduce the risks of dementia. Number one is diet and exercise. When we look into diet and exercise, we know obesity, not having a regular diet can actually increase the risk of dementia due to the fact that you've got multiple risks of having a lot of different types of chronic diseases like diabetes, hypertension, heart failure, liver problems, and things like that. Alcohol use, excessive alcohol use would also affect the factor for the risk factors for dementia itself. Cardiovascular risk factors, if you have a family history of heart failure, heart attacks in the family, you might want to look into how to modify and reduce the risk of cardiovascular problems. Depression would usually, mental health also affects dementia, because when someone has mental health issues, they will actually affect their lifestyle itself, how they eat, how they move around, their hygiene, what they're thinking about things like that, and it all comes as a whole, and it depends. It affects that someone if they've got a depression or any other mental health issues that's not being looked into. It might lead to higher risk factors of dementia. Diabetes, smoking, sleep apnea. Sleep apnea is where someone, usually when they sleep, they actually pause breathing. They stop breathing. This is usually seen in someone with, especially commonly seen in someone with obesity. Right? And what happens is that someone is going to stop breathing because of the airway obstruction due to the tongue falling back to the back of the throat. And sleep apnea means you don't get enough oxygen when you're sleeping at night, and that causes for some degree of hypoxia to the brain at certain times, and that actually becomes a risk factor for dementia itself, because you don't get enough oxygen to your brains every single night. All right. Vitamin and nutritional deficiencies. So certain supplements, certain vitamins and nutrition are very important for brain health. Nowadays we hear a lot of different types of supplements, omega-3, a lot of other things that are very that are promoted to increase our brain quality, our thinking skills and things like that. Up to the point that you see smaller children eating a lot of supplements as well. So yes, vitamin and nutritional deficiencies can cause a higher risk factor of dementia. But I think a healthy diet and lifestyle adjustments regarding diet and exercise and use of alcohol and things like that will be very important to contribute to reducing the modifiable risk factors for dementia. So for someone with dementia, these are the few things that we see in these people, all right? And it all relates to their thinking skills, their thought processes. Number one would be memory difficulties. Sometimes they actually know what it is, but they can't say it out. For example, if they say, I need to sweep the floor with, that actually involve thinking skills and thought processes. We call them non-cognitive characteristics. When someone has dementia and has all these thought processes problems, it leads to, it can change someone's personality and their behavior and attitude, because it gets very up to a point that it's very frustrating for that person. I can't even remember what the room is like. You want to get a room, but you get a mop instead, things like that. And it doesn't fit your purpose that you want to sweep the floor. And it comes to the fact that it becomes very frustrating, very demotivating, and it induces a lot of behavioral disturbances. They get a bit restless because they're thinking about, a lot of things. What did I forget? What am I doing in this place? I don't recognize this room when it's their own bedroom. I don't know where the toilet is. When I don't remember where the toilet is, I can't, I'm going to have incontinence. I'm just going to, wet my pajamas, wet my pants, things like that. They've got wandering, they've got violence. If they can't remember their family members, who they are, they might think that they're strangers. They might have delusions and paranoia, thinking that someone is out to hurt them and things like that. And social and sexual disinhibition. So this type of persons, when they get frustrated with the lack of their cognitive skills or the lack of their thought processes, they will withdraw little by little from the community itself naturally. And that will cause a lot of problems, not only to the person living with dementia itself, it also causes a lot of problems with the caretakers as well, because they're drawing themselves away from the family even. So what are the things that you might want to see in someone with, suspected of dementia? If you want to look into whether how subtle or how repeated it becomes, okay? Number one, we look at someone who repeatedly asks the same questions. And it's not like today, it may be subtle, today they ask the same question. When is my son coming home? Then you say, oh, the 22nd of April. It's today at 5 o'clock. And then when, 5 minutes later, they're going to ask again. And then they're going to ask again. So this type of things is because they can't remember, they've got memory dysfunction. They get lost or disoriented at their own home. They might not even recognize their own room. They're unable to follow directions. When they go out, some older people, we've got older age groups who like to go out in the community. All right, going to parks, going to the market. It's something that's very natural to the old age group. And losing their way is also another thing that can actually trigger families. She has gone to the market every week. This certain market every week for the last 20 years, but yet today she lost her way. She comes back, the mother comes back and says, I can't remember where the supermarket is. They move it. They move to another place. That will be one of a very subtle trigger as well. They might be disoriented to the date and time of day. They might recognize and is confused about familiar people. They may have difficulty with routine tasks, things that they've done for so many years: cooking, cleaning, self-hygiene. Some people even caring for their grandchildren. They might not even recognize their grandchildren, things like that. And when it comes to the point where they get frustrated and demotivated and depressed about it, they will start to neglect their personal safety, their hygiene, and their nutrition. And this is very important because their life is on the line. Knowing the age group, we know that these are vulnerable population. We have to look into their personal safety, their hygiene, and also their nutrition. So the cause of dementia itself, it's according to the type of dementia as well. It depends on the type of dementia. Usually things like Alzheimer's, dementias like Alzheimer's, because it's a progressive type of Alzheimer's, it ranges from 7 to 10 years. Compared to Alzheimer's, compared to dementia, due to a stroke, it can be overnight, depending on the damage of that has happened to the brain. And as this disease or this condition progresses, it gets more stressful to the caregivers and the family members, because they may require increased care, in the sense that the activities of daily living are affected. Going to the toilet is already a big issue already to this type of people. They may forget to go to the toilet to void. They may forget their food. They may forget to take their meals. They may forget to take their medication. And all this comes into play and affects the overall health of the older person with dementia. So what is the healthcare community assisting with dementia? How do we look into dementia itself? When we've got someone who we think has dementia, this assessment and diagnosis process is actually multidisciplinary, and it involves the doctors. It may involve the psychiatrists and the psychologists, the nurses, social workers, especially for those with low income group, and rehabilitation therapists or the physiotherapists, occupational therapists. It sometimes even nutritionists and dietitians will be pulled into the game as well to help ensure that the management and intervention of someone with dementia is holistic. Holistic means we care for them all round, 5D, not only 2D. All right, multidimensional care. Okay. So a focus of assessment, we look into the level of function of that person. How well can they be independent as much as possible? We look at the factors that affect the person's level, the person's response to his or her illness, how frustrated they are, how disturbed they are, and things like that. And we also ask a lot of things during assessment itself. And it seems to be very lengthy sometimes when we bring an older person, an older family member to the geriatric clinic, and the doctors, the nurses, and the therapists all ask similar questions and a lot of questions. But we want a complete medical history. What you may actually tell the doctors regarding your father, you may have missed out, and the nurses or the therapists can actually catch. And it will be very holistic. Okay, so complete medical history and physical examination, a review of all the medications. Like I said, persons with dementia have polypharmacy. They've got different types of medications to cater to the different types of chronic diseases. A functional assessment, we will do some certain tests to see whether they can function as independent as possible. A comprehensive psychosocial and formal mental status assessment. We've got a lot of tools that we can use to assess how mentally stable and how disturbed they are, and whether they're very sure of themselves and things like that. And we also assess the environmental and the caregiver influences, whether we know that the caregiver actually supports fully in the intervention of dementia in that person. So a lot of things that is for the interventions and the management of dementia. Like I said in the definition, dementia is usually progressive and not reversible, except that if it is dementia-like conditions due to other causes. So interventions and management has to be very highly individualized, because one person A may be more emotionally stable and more independent compared to person B. So it has to be a well-tailored and customized management plan and intervention plan that involves the healthcare personnel, that involves the caregiver especially, and also the community. So that's our desire here, so that you've got this well-rounded community to care for persons with living with dementia. So a lot of emotional support, especially for the persons living with dementia, and also the caregivers. If the caregivers are burnt out, it may have problems where they may be demotivated, or they may actually stop caring for the person with dementia. And this is where we hear cases of abuse and things like that. Environmental management, self-care assistance, fall preventions. This is where we cater to the safety issues of the person moving about in their homes and in the community for, to ensure that they don't hurt themselves. Humor, memory training, music therapy, lots of therapy that involves a lot of, thought processes. So some people may like music, and music actually helps with thought processes and their emotional stability. Some people may like their grandchildren around them. Some people are older age groups, they like, children a lot around them so they can play magic tricks with them and things like that. It helps with memory training. It helps with presence. It helps with reminiscence. They remember their children when they're about this age. I play magic tricks with them. So with smaller children like grandchildren coming in to visit, they get that reminiscence therapy as well. A lot of spiritual support, a lot of touch. It's very important that we keep very connected to these people with dementia to help them to prevent into regressing too fast into their dementia stage. And it helps that when the dementia progresses more slowly, the caregivers are less stressful. So safety issues, when we look into behavioral disturbances of someone with dementia, we've got wandering, we've got, restlessness, and this type of people, they might actually wander out. I remembered I cared for an older person who actually drove out from his house all the way up to Syrian and couldn't find his way back. And he has been driving for many years as per the grandchildren. So this type of things tells you something as well. So you make sure that the person carries some form of identification along with the phone number of someone to call. We also look into the safety of the patient or the person with dementia in the house itself. If you've got kettles that you need to use to boil on the stove, maybe change it to automatic kettles, smoke alarms, alarm devices for doors to prevent wandering. Things like this are very, very common nowadays, and everything is very high tech. Even the locks on your doors, you can actually activate using your Wi-Fi, and you can get alert. You've got CCTVs in every homes, basically. It's a very common thing nowadays. And keeping medications, cleaning solutions, and any poisonous chemicals inaccessible places. I usually term it with my students, it's like caring for a small child who doesn't realize the safety issues of all these things as well. So it's similar to that. You're trying to proof the house to make sure that the person with dementia does not hurt himself or any other person in the household as well. So those are the safety issues. We want, when we talk about safety issues, we don't want to cage them as well. We want them to also try and be as independent as possible. ADLs mean activities of daily living, eating, bathing themselves, putting on their clothes, cleaning up their rooms and things like that. Those are activities of daily livings. So we try as much as possible to ensure that these persons with dementia actually have the highest possible, the most optimum level of independence when they're doing their activities of daily living, especially when we catch the dementia in an early stage. That also helps with their thought processes because you keep the activities as routine as possible. All right, it becomes a bit more comfortable for them to go through their lives. When they get up, they drink a glass of water to keep hydrated, they go to the toilet, things like that. So we need to keep the activities of daily living as simple and routine as possible. If they are not able to cook, for example, maybe when you do a schedule for that person with dementia, you might want to plan out, drink a glass of water in the morning, and then, go to the toilet, go for your bath and void, and then go to the kitchen. And the kitchen, you just, open the container on the table. That's where your breakfast is. It's already prepared for you. And where you keep the cutleries and things like that. All right, so as simple and as routine as possible, and that helps with their thought processes, and it gives them less frustration when dealing with their dementia, because they may not even realize that they're dealing with dementia as well. Keeping the routine as consistent as possible, but to recognize that they will have to be changed as the person's level of function changes. So dementia and Alzheimer's, it's a progressive disease. So at a certain point of time, it will change. The level of function, it will change. What today, maybe that person may be able to brush their own teeth, for example. The next couple of months down, they don't even know what a toothbrush is for, all right? So if the person needs assistance with hygiene, use statements that they may actually remember that all the activities that's related to that activity, all right, to that, session. So for example, if it's time for him to do self-hygiene, you might actually trigger the thought processes by saying it's time for your bath. So they would, then you will put in the routine of, okay, take your towel, take your toothbrush and your toothpaste with your cup, and also go to the toilet. Toilet is right here, things like that. So routine is very important, and planning it out usually gets caregivers a head start, gear 2, gear 3 already, and it makes it easier to live with someone with dementia. Okay, so I've talked about the person with dementia itself. We're going to focusing on the caretaker, and caretaker burnout is a very common thing in the community. I don't know if Mr. Dennis himself has actually had any members in the community telling him about, how difficult it is to care for someone with dementia itself. Have you seen any cases that's already talked to you about those with dementia? Any significant others?
Not in particularly on dementia, but in a general term, we are much concerned with other diseases. We work on preventive measures that dementia must not happen, and also dementia is preventative. So we work on that aspect. We have touched much on the effects and the cause of dementia. That is a good point. We in Sarawak Gerontology and Geriatrics Society will move forward with the knowledge gained today on dementia in particular. So for the caretaker side, I would like to add that Sarawak is under the hospital management of the geriatrics ward in IJS. I think it's 7th floor under Dr. Tiong In Kyung, who is a geriatric specialist, together with Dr. Ling Jiani. We will look into the dementia aspect on how the caretakers can use that platform to volunteer or to assist in their quest to make dementia and Alzheimer's patient more comfortable and acceptable to society.
Well said, Mr. Dennis. I think the society itself has a lot to say also in the community, especially for Kuching and Sarawak itself. I will go into looking into the caretaker and see what we can do to advise people who have stresses as being caregivers and caretakers of someone with dementia. So the challenges for dementia caregivers, there's a lot of things. We know for sure that commonly, significant others, spouses, partners in the relationship are usually the common persons who will take over the role in caregiving for persons living with dementia. And that's a very common thing in our community as well. We know, cultural wise, it's usually the significant other who cares for their spouses, and it gets very difficult for those who are also having, health issues of their own, and still need to care for their spouse or their significant others who also have issues with chronic conditions plus dementia itself. Even with those who are children of, persons with dementia, they may be at an age that is closer to the older age group already. Some 14% believe that, their physical or mental health is not good enough to provide care. Nowadays, with a lot of multiple diseases in the community, things like diabetes, hypertension, things like arthritis, you see a lot of arthritis and gouts and, back pain, things like that in the community. It hinders the proper care for someone with dementia, especially with late stage dementia, whereby you need a lot of caregiving, moving the patient from the bed to the chair, moving the person, getting the person to the toilet. If they're having incontinence, for example, changing the bed sheets every day, that's a lot of things to deal with. All right, and it gives a lot of physical and mental health challenges for caregivers. It comes to a point that caregivers cannot take care of themselves. All right, they delay and they do not do things for their own health. So certain studies actually say that some caregivers with long-term patients, not only for dementia, persons with dementia, caregivers develop multiple chronic conditions like hypertension, diabetes, and things like that, because they do not have the time to cater, they do not have enough time to cater to their own health, due to the fact they are fully concentrated on caring for that family member with dementia, right? So 66% said caregiving actually interferes with their ability to take care of themselves or their daily activities. And it's not only daily activities that's affected. Sometimes financial status of the family itself would be affected as well. For example, if a caregiver would have to stop working in order to fully care for a person living with dementia in the household. So that's an income there lost as well. Focusing on the caretaker. So this is just a comparison between caregivers that do not care for people with dementia and those caregivers that deal with dementia. And you can actually see how many hours per week you spend actively caring for your loved one. More than 25 hours will be 26% of those dementia caregivers. And that's a lot of, time for the caregivers to be putting into caring for their loved ones with dementia. And this is because they know that certain levels of dementia, the independence of the person with dementia is regressing. So you'll have to put in more and more hours, and that will affect the caregiver or the caretaker, the whole psychosocially and physically. All right, so you've got a lot of stresses. This is just a little flow chart that describes the stress health model. All right, so a lot of stresses that we see in the dementia caregivers. You've got, the primary stresses, which is the person living with dementia itself. So because the person with dementia itself has all these disabilities, these problem behaviors, this loss of skills, of thought processes, which reduces their independence in dealing with their activities of daily living. These are the primary stresses that can affect the dementia caregiver. And then secondary stresses will be because they are dealing with the primary stresses, other secondary stresses will come into play as well. Things like family conflict, work conflict, society conflict and things like that. All right. So you see that it comes whereby it goes a lot into looking into the demands of the recipient itself, looking into the perceived stress, looking into the emotional and behavioral responses of the caregiver. All right. Sometimes the consequences comes to a point that the caregiver actually, gives up on the person with dementia itself. They get even sicker than the person with dementia itself because they are not caring for their own health physically and psychologically. So when we look into how to deal with all this caregiver exhaustion or caregiver burnout, all right, we know in our culture, especially the Malay culture, our Malaysian culture, we have that sense of responsibility that is very strong in whereby if a parent or an older person in the family is afflicted with something, the second generation and below would actually try their best to deal with whatever needs to be done. I remember I've got, they're taking over. So I've had a patient with stroke and we are actually teaching we were actually teaching her how to feed herself again with her own hands. She had weakness of one side. And we're trying to train her to be as independent as possible. But because of our local culture, whereby your children or your grandchildren are trying their best to cater to your needs, I'm not saying it's a bad thing. It's a good thing in a sense, because you've got that sense of responsibility. They start to feed her, like a baby, start to feed her. And this is whereby we know that the independence training for that person with dementia or for that person with certain disabilities that can be trained again will be stopped. And it will cause a lot of problems with the caregivers later, because it will cause the person with dementia to be 100% reliable on the caregiver. And that will stress that caregiver out. And it is very common whereby when that person with dementia is, firstly diagnosed, you would see a lot of input from, caregivers. And it comes to time that when the disease progresses, you will see less and less caregivers, but with more and more work in a sense. And it's very common in the community as well. So when we talk to family members who have, who have the idea that, okay, we are going to deal with this for the rest of my mother's life or my father's life, and we know that it is going to regress. So we're going to set reasonable goals, all right? If they're still at an independent stage, we try to keep that independent stage for as long as possible. That's where you create simple and routine activities. You might want to know your limits, all right? So some caregivers, they want to, set their objectives, the sky's the limits. So they Google up everything, they look up everything that's being, done in the Western countries, and they want to try out here in our society where we don't have the resources. That's going to be difficult. Number one, it's going to be difficult to, keep track of. You can't actually keep consistent of certain things and activities and interventions. Another one, it will also cause stress to the person with dementia itself, because the activity is not available, the resource is not available all the time. It cuts the routine from their daily life. And it also gives a lot of frustration to the caregivers. For example, okay, today I can give this, activity or intervention. To 2 weeks down the line, I won't have enough money to, put her in this intervention activity. So the caregiver needs to know their limits. All right, be realistic and know their limits to understand what you are dealing with. So caregivers will have to understand that for patients with dementia, persons with Alzheimer's, for example, I'll highlight Alzheimer's because it's very, very important. You need to understand that, okay, number one, it's irreversible. Number two, it's going to progress, but we can actually see how fast it progresses. We can intervene so that it can progress even slower than it's expected to progress. And all these activities that we set will help with the slowing down the progression, things like that. Understand the complications that can come with someone with a certain level of dementia. For example, dehydration. Some persons with dementia may have fear of incontinence because they can't find the toilet. Then they stop drinking. And that actually causes the bladder to be more irritated and void more frequently and cause more incontinence. And that will also affect the skin integrity of the person with dementia, especially at night. When you've got someone with dementia who's not drinking well, not hydrated, and you've got someone who is unable to find the toilet in the middle of the night, and you as the caregiver are actually sleeping and resting, and they come, they actually void on the bed, for example. They might not actually remember that they're voided on the bed, and that will have problems with their skin integrity, things like infection, because their hygiene is already affected, right? So understand what you're dealing with is very, very important. If you've got someone with dementia, you need to talk with your healthcare personnel, your doctors, your nurses, your therapists, your psychologists or psychiatrists to see how much needs to be done and what are the limits, all right? Where do you draw the line to say that I'm not going to do this because I want my mother and father to take control of his life still, to be as independent as possible, because that will help with their emotional stability. So customizing these individualized plans is a tricky process because you need to go through it first and then you'll adjust as time goes by. All right. Learn to accept feelings. You might feel frustrated. Yes. You might feel anxious to the point that, your family member is going to wander around. They might not remember the way home, but they remember where you keep your house keys. They remember how to go out of the house, but they may not remember to come back to the house. So things like that, you need to accept the feelings of anxiety. You know that you're going to be anxious. You know you're going to be disturbed. You know that you're going to be emotionally stressed out when you're dealing with someone who's resisting your aid, for example. And this is very important because when you induce independence in someone with dementia, it also helps with lessening the emotional resistance. For example, if that person has dementia and maybe initially have slight problems with feeding themselves, they don't know between the fork and the spoon and the knife, or they can't handle the chopsticks and things. They don't know how to use the chopsticks. We caregivers should be able to adjust it where they can customize or tailor fit that, okay, instead of using chopsticks, we're going to use a spoon and you can still feed yourself. And that's where emotional resistance and demotivation can be stopped. And it gives less stress on both sides, the person living with dementia itself and also the caregiver who's dealing with dementia. All right. So independence is very important in persons living with dementia as much as possible. If they're still having mild stages of dementia, this is very important. All right. Reach out and trust someone. This is where the community needs to know that stigma and awareness is, stigma suppression and awareness is very important when we talk about dementia-friendly communities where we accept people with dementia. All right. My experience when being overseas, we do see older age groups being very, very dependent, even though they've got dementia, but we can't blame them. They've got really good resources. I think it has come to a time where the community has to be very, very alert on people living with dementia, giving very positive mindset to their neighbors who are caring for people with dementia, keeping an eye out in the neighborhood. Simple things like that would actually help the caregivers care better to the persons living with dementia. A support group helps. I don't know if in Kuching we've got a support groups for people who are caregivers, who are caring for people. It may not be just caregivers for persons with dementia. It may be a support group for caregivers as a whole. Caregivers for persons, with vegetative states, those who are in coma, those who are bedridden, support group for those who are dealing with someone with cancer, terminal cancer and things like that. So a support group actually helps in the sense that each person has an individualized experience and can share their knowledge to help the other person. All right. I know for groups like in Kuching itself, we've got all these groups for autistic children, hyperactive children, learning development children. They're very big on it. But I think it's high time we also look into our older age communities as well, because they still contribute to the community as well, especially to the younger generation. So a support group helps a lot in this sense. Staying healthy and positive. If you are setting your goals reasonable, if you know your limits, if you understand what you're dealing with and accept your feelings, if you accept help from someone, if you've got, people sharing their similar experiences, it may not be 100% similar. If they actually contribute to keeping you on the positive side, it's very, very helpful to the caregiver as well. And to be realistic about the condition. If your family member with dementia has, advanced dementia, and it comes to a state that they can't really move around, they're very aggressive, you need to be realistic that it's not what they are. It's not who they are. It's the conditions of the brain that is causing them to be this way. That's not what we want to remember them by. So you need to be realistic in the sense that if it comes to that advanced stage, we do realize that a lot of care needs to be put in. The community should realize and be aware that, okay, this person is aggressive. We see them in the neighborhood, shouting at their own daughter or their own children. We do realize that, okay, this is not who they are, but it is what has happened to them. All right. So dealing with all these issues actually help with reducing caregiver exhaustion or caregiver burnout. And in a sense that it also protects the person living with dementia itself, because you get caregivers who realize what is to be done, who has less stress, who has less risks of going to neglect or abuse the older person itself, who has no idea what is going on. Okay. So when we talk about, caregiver workout initially, then we also look into how you work to become a dementia-friendly community. The Western countries, we do talk about dementia-friendly communities. They've got a lot of resources and help from different stakeholders in the community itself. So you've got a lot of things that we can use to cater to those people living with dementia itself. All right, the community itself is actually very important. All right, so things like the healthcare side, you've got professionals who are trained to care throughout the continuum from the first time that the person has been diagnosed with dementia. It may be still very mild dementia, and that care would go forwards up until the point that we give palliative care to persons with dementia itself. So this care in the healthcare setting, we call it holistic caring. We not only see the patient as having dementia itself, we also look into other aspects like their chronic conditions, their medical conditions, what is needed for them to gain independence and things like that. And other types of contribution for the community itself, it comes from outside. Things like communities of faith, the churches, the mosques, the temples. If you've got support groups from all these communities of faith, it's very helpful for those persons with dementia, and it's also very helpful for caregivers with dementia. All right, neighbors, I cannot highlight more. Neighbors, community members, and friends are very, very important in the life of caregivers and persons with dementia. And it comes to a level where, you know, stigma, the what do you call it? The level, the state, the state of understanding dementia itself has to be changed. I think here we talk, most of our persons with dementia may still go undetected. All right. People will say, you know, it's just aging. We just forget stuff every now and then. That's fine. It's just aging. We're getting old. That's fine. And it comes to the fact that, you know, it gets worse and worse, and the independence, the independent living gets worse as well. They get less and less independent, and it will stress everyone out. Okay. Healthcare facilities also have got the emergency planning and first response. You know that older age people comes with a lot of comorbidities as well, not only with the dementia. And if you've got, you know, problems in the house, healthcare issues in the house, and you need emergency planning and first response, just make sure that when you've called in a healthcare personnel to say that, you know, my father has mid-stage dementia, late-stage dementia, so the healthcare personnel would understand that they may not be able to get much info from the person living with dementia itself, but they will look into the primary caregiver of the person with dementia. So that depends on the community. You know, if we as a community decide to initiate, there's a lot of things that can actually be done in this sense. Maybe Mr. Dennis can actually talk about how the community can contribute and how caregivers and those persons with dementia can try and slow down the progress of dementia itself, or prevent dementia in a sense that, you know, try and stop any occurrences of dementia. I think you've got a few points for that as well. I'll hand it over to you, Mr. Dennis.
Thank you very much, Dave and Dayang. Well, there's so much to know about dementia, so much. We in SGGS, or Sarawak Gerontology and Geriatric Society, do have, in part, to share as far as dementia, Alzheimer's is concerned. And we should work in tandem together with all the other caretakers group, especially in Sarawak. For Sarawak itself, Sarawak Gerontology and Geriatrics are more concerned with the healthy elderly on preventative measures to avoid dementia and other diseases that comes in relation to the elderly. When we talk about elderly, we talk about anybody who are 55 years or 60 years above, which also relates to our Kenyalang Gold Card prerequisites of 60 years and above. It is very important we talk about, when Dayang talk about stigma. Well, it's a new area for SGGS to look into. A very big area. The area concerned is twofold. One is the educational and technical on the medical aspect. The second is the area of Sarawak. It's so vast, from the first division right up to Lawas there. How are we going to bring this awareness into them? The medical people have done their part. We see there is an area where the medical fraternity and the social ministry comes in, where the medical people starts or stop their never-ending responsibilities, and where the social ministries comes in, or interrelated otherwise. Here we look into the much concerned demography of the population of Sarawak. It states that 50 million or more worldwide. We work on a 15% where our elderly in Malaysia or anywhere else is the bracket. And when we look into that 15%, half of this, or the minimum 30%, will suffer from dementia. That is a lot. Each community really have to handle. So we look into another demography. It takes 7 to 10 years, as indicated, that dementia is to be built to fruition, that dia jadi masak, okay? That they become sick. I think it's more important that we look into these years, that we must address these 7 to 10 years and further down the road to make the potential dementia patient to have fun and to be happy, to cover the balance of years, maybe to prevent them to fall into that dementia category. And when they fall into that category, it's suffering. So in practice, it's better to be happy than to suffer. We see in the caregiver group, we saw many conditions. We saw the dementia patient. We saw many causative agents that make them to be like that. In part, it's actually growing a plant named dementia. Like a plant we call orchid. We nurture them to be sick, actually. We nurture ourselves to be sick. So we must prevent that. Because we know it. Since we know it, why allow ourselves to be the subject and the causes of how we are in that position in later years? with all the pointers that Dayang, you actually gave that knowledge for us in SGGS to share and educate. We share that in our quest to ensure our healthy elderly be knowledgeable enough. We will be doing a roadshow to all the major towns in Sarawak, Sri Aman, Sibu, Bintulu, Miri. We will mention dementia as part of the subject matter of discussion. And in many instances, we include all the diseases in our SCGS objectives. Now, we want to focus at least on dementia and Alzheimer's in particular too. We actually talk about falls and of elderly. Now, one of the causes of elderly is also dementia and Alzheimer's now. So we will put much effort into looking back to our objectives that we are propagating to the various population in Sarawak. This is one part of awareness that it is much effort required. There are also, we have a group that goes to visit the elderly. We do road trips. We have groupings. And these are the people we are sure that their dementia and Alzheimer's is guaranteed not to be affecting them because they are full of humor, they are more full of fun. We cannot measure the effects, but we can actually feel that the need is there to be happy, to avoid the onset of these diseases, especially now we are talking about dementia. We got our music group. In the past, we do hold weekly music sessions. We brought in our members to sing and to dance. I am sure they are happy. I'm sure they want it to continue. But because of our current situation, we are unable to do so. But rest assured that SGGS program and events are still planned. Actually, we plan it anytime MCO is relaxed. We are there to help with the elderly in our group and to invite people to share the activities to avoid what we are talking about today. We actually also have our own SGGS website where we talk about healthy living protocols, health-related subjects. We are going to make it, we are actually reserved for members. Now we're going to do it for public because we are embarking on a huge website that we are employing. I think this all boils up to how mature our community is. And it's our responsibility to make our community be mature compared to all the advanced countries around the world, especially in our ASEAN region. When we talk about ASEAN region, Sarawak Gerontology and Geriatric Society will have a forum on the elderly, which I will invite speakers on dementia in 2022 on gerontology itself. And this year itself, we got our own state forum. These two, we will invite speakers for dementia and Alzheimer's. Touching on caregivers, caregivers is a big part of the dementia sickness, a big cake. And this is the cake that has been continually baked. But the caregivers community does not expand as fast as the cake that is being baked, where the disease is concerned and where the population of dementia people are concerned. So there is a disparity here as far as the ratio of the caregivers and the growth of the dementia patients are concerned. We will assist where we possibly can. It is important that we in SGGS do not know everything. Neither does everybody knows everything. But please let us know where we can assist you, where we can link you, where we can fill your forms to assist you in the social welfare that you deserve, that you may need. I think we will continue to talk more when there are subjects that actually relates to what we are talking about. Okay, Zoraina? As for now, we will take 5 and then we will come in again when the subject matter qualify us to amplify more. Thank you.
Thank you, Mr. Dennis. I think I'm going to do a quick conclusion of our talk this morning, and then we'll go straight into question and answer. All right. As a whole, you can see that dementia itself actually concerns everyone in the community itself. Every person in the community has a role to play in caring for that person living with dementia in order to ensure that our society moves smoothly. And dementia-friendly communities have been proven to change the way people think about dementia, because the issue of stigma itself is still there. People are sometimes afraid to be diagnosed with dementia. There's some people with mild dementia are actually afraid. There's the fear of, being labeled as babo or nyanyo and things like that. And they're reluctant to speak about the condition, okay, or they may actually speak lightly of the condition. I just forgot my keys today. It's fine. I'm just being a forgetful person. It's just aging. For dementia like Alzheimer's, it's not just aging. It's a progressive disease, and we need to recognize it first and foremost. So in order to try and reduce such stigma, we have a big need for advocacy approaches. All right. Just like when we have advocacy for those with cancer, just like when we've got advocacy for those with autism, we can see you've got Autism Day that's very big in the community. Everybody knows, and when they see a child with Down syndrome with all the features, now you see the community, they will quickly recognize someone with Down syndrome, and they will make leeways and they'll respect the person and the caregiver that has that mindset has to there as well. So the stigma of dementia has to be, reduced, and the acceptance that dementia does exist in our community here. It's very, very important so that we gain that respect, we gain that support from the community itself. All right. I think a lot of collaboration has to go into play, whereby the healthcare professionals can collaborate with like the Sarawak Geriatric Gerontological Services in Society. I think we can actually cross-check our links and our networks and our cables so that we can help with persons living with dementia, and also exceptionally for those who are caregiving persons with dementia as well. It is very important to recognize the very important role of the caregivers. So the society, the government, the community may actually be considering an increased input of resources. So caregivers may not only be fully catering to the needs of the person with living with dementia, but also catering or helping them to have a balance in their life, a balance of their work. If they've got income problems because they've stopped working due to caring for a loved one with dementia, how are we going to help? If they've got mental health issues, who is going to, give this support and consult them and, try and make time for them? I think at the grassroots level, it's very, very important to look into who's going to be the important stakeholders, the champions of, providing a very good impact in dementia itself, providing a positive attitude, a positive impact into dementia care, which involves not only the family members of the person living with dementia, but also those in the community who can actually contribute in caring and keeping persons with dementia safe, healthy, emotionally stable, happier, and things like that. When Mr. Dennis actually talked about COVID-19, when they stopped the activities due to COVID-19, I would understand well, because your group is in the vulnerable population group, and we do not actually advise you to mingle around as much as possible. It also triggers that, when we've got less communication, especially for someone with living with dementia and their caregivers, the communication level during this pandemic period is very, very reduced. Help may be delayed. Consultations for persons with dementia may be delayed because you've got, healthcare centers trying to space out their appointments, trying to cater to the primary objective of curbing COVID-19 infection itself. Sometimes we cannot help it. But it doesn't mean that we forget these people with dementia, that this is where the community can put themselves into in helping with the support system itself. So looking out for those with dementia, asking, their caregivers how they're doing, that in as little or as much as possible helps with the emotional support. And if you're able to support in other, material wise, or, with other resources, well, proceed and go ahead. Bearing in mind the SOPs that we've got during this pandemic period. I think with persons with dementia, the communication is important. The activities that caters to their independence and their routine and preserving their thought processes as much as possible is also very important in this sense, in trying to prevent a very fast progress of the dementia, which in turn helps reducing the stress of their caregivers and the loved ones around them. I think that basically sums up our talk for today, Dave. I'll open the floor for a few Q&A questions that may be on the chat group for Facebook and YouTube. Thank you.
Right.
Thank you very much, Dayang Zoraina, and thank you very much, Mr. Dennis Tan, for that very informative discussion and also sharing. Like Dayang just mentioned, we are opening the floor up to questions and answers. So we'll be picking your question and questions from your a Facebook post as well as YouTube post. So if you're interested in getting questions across to the panels, please post your questions on either the YouTube page that you're on or the Facebook page that you're on currently watching and turning into this webinar, and we'll pick up your questions shortly. Perhaps just to start the ball rolling, I have a few technical questions here. I think I'll send these questions your way, Dayang. Yeah. So the first question I think here is from Susie. Is dementia age-related only, or can it be also caused by other medical conditions? I think you covered this earlier, but perhaps you can re-emphasize that. Yeah.
All right. Like I said in the early definition part of our talk today, dementia is an umbrella term where you've got problems that affect the cognitive skills or the thinking processes and thought processes of that someone experiencing dementia itself. And dementia is just a big word for so many different types of conditions. The most common one is Alzheimer's, and that's a progressive disease which you see in older age groups commonly. Doesn't mean that the middle-aged adults, younger adults do not have Alzheimer's. Just that it's a bit rare because of progression of the disease itself. But other other causes like traumatic brain injury, where you've got hypoxia, less oxygen supply, less blood supply to the brain, can actually cause symptoms and dementia-like symptoms. So, like I said earlier as well, diseases, autoimmune diseases like Parkinson's, Creutzfeldt-Jakob disease, Huntington's disease, where it affects the structure of the brains or the brain cells and the neurons, and it affects the function and the connection of the brain waves, is actually a sort of dementia as well. So yes, it may not only happen in older age groups, it may be triggered in younger age groups as well, depending on the type of triggers or cause factors that causes that dementia. Even patients with strokes do have dementia as well, depending on the location of the damage in the brain.
Right. Okay, so that's very clear. And I think there's a follow-up to that question as well. Is there a common age at which dementia onsets? Is there a common age where people get dementia?
This is quite a tricky question because due to the fact that our community realized dementia as being late, when we suddenly recognize dementia at the age of 80, it may actually have progressed 10 years ago. And that's why I really highlight on stigma and awareness of dementia itself. I don't think it's fair to put a common age to dementia because of the many different types of dementia. Yes, you may actually put in Alzheimer's possibly because it's very commonly detected among the older age groups, older persons. But it's not necessarily, dementia is only in older persons. No. All right. This is a common misconception of dementia itself. Like I said prior to my answer to the previous question, it's being caused by something. And what is the causative factor affects that type of dementia. And things like strokes, I've seen people who are 18 years old having strokes may have dementia as well, and things like that. So it's not fair to put a common age on dementia as a whole, but we do see a lot of older age group members having dementia because, number one, it's a stigma that, the older you get, the more babo or nyanyok you get. right? Or the older you get, you get more forgetful and things like that. And then it comes to a step that when it gets really bad, then we seek professional services or healthcare services to diagnose that dementia for us. So it may have already been there 10, 20 years ago, all right, commonly 7 to 10, but we've already recognized it late. And that's a big issue for us now. Then we will have to cater to have greater stress for the caregivers because we recognize it late in this sense. I hope that gives a clear answer.
Yep, you did, Dayang. And just a very, very quick question for you as well again. Are there any medications to prevent or even cure the dementia completely?
For things like Alzheimer's, which are progressive dementias, it is not reversible, but you can slow down the progress of dementia itself. For example, if someone has mild dementia, you can put in interventions to try and slow down the progress whereby they can be as independent as possible for a longer period of time. For certain cases like dementia-like symptoms, these are not dementia, but they've got symptoms of dementia. Things like those people with autoimmune disease of the brain, those with infections, those with sepsis, those with metabolic diseases like kidney problems, they may present symptoms like dementia, but once you correct it, it's actually reversible. So it depends on the condition. It's very, very individualized. It depends on the condition of the person itself, whether it's a progressive type of dementia or whether it's just because of a primary factor. So it's sort of like a secondary dementia due to a primary factor where it is treatable and reversible.
All right. Thanks, Dayang. Maybe next question, we'll shift it over to Mr. Tan. This is a question from Sidia. Could you identify champions among your SGGS members who could initiate and lead the dementia-friendly communities? Mr. Tan.
Thank you for the question. First of all, SGGS works in a team. We got a committee and we meet regularly on WhatsApp group. Currently, we do it in the process of Zooming. But whatever the subject matter is highlighted, we will first discuss it casually, then we will minute it, and we will create it as a matter for us, as a target focus for us to look into. Would that answer your question?
All right, Mr. Tan, I'll let Sidia get back to us in case we didn't adequately answer her question. All right, sticking with you, Mr. Tan, Dayang highlighted the lack of community support groups, especially for caregivers of individuals with dementia, possibly leading to caregiver fatigue and burnout. I know the scope of SGGS is very wide, but perhaps, Mr. Tan, you could enlighten us on whether there are any NGOs out there looking into the interests of caregivers specifically.
I will not be able to share with you on the caregivers' wide scope of requirement that they may have. But as I said, the medical department in our state will be looking into it, and actually there are, as I read from the posting of the Borneo Post and the Past Tribune, that the caregivers group will be formed in Sarawak. And I see pictures of my dear friend, is actually the advisor of our Sarawak Gerontology and Geriatric Society, Dr. Gary Tiong In Hien of the Eye Institute Jantong Sarawak, IJS. And he, in the picture I saw, there is a workshop that he did for the community and the caregivers. I think that would be currently the direction. And if you want the contact number or some information on him, I may ask his permission to be shared with you. Okay, thank you.
Right. Okay, Dr. Tan, Mr. Tan. Okay, I think we'll go back to Dayang Zoraina for the next question. One of your slides mentioned focused on assessment types. Yeah. So this is a question from Azani. How can she find help with assessment of environment and caregivers?
I think for our healthcare side here, when you get your loved one who's suspected of dementia goes through assessment, the therapists or the physiotherapists in the healthcare center would be the best person to refer to in regards to trying to cater to the safety needs of the person with dementia. If you need, mobile assistance, if you need modification of certain things in the bathroom, I think our physical therapists, our occupational therapists would be the best person, or even the nurses would be the best persons for you to go to, because most of the time these people will have the connection on the outside to persons who can supply these things, who can supply the support for you to care with regard to care the person with dementia with regards to the safety issues in the home. So if you need to say modify, you get a mobile toilet for their bedroom and things like that, the nurses and the therapists in the hospital or in the care center that you bring your loved one to would have the information that you might want to have. And I think for Mr. Dennis and his society, I think they also have all this context as well, probably. Yeah.
Thanks, Dayang. Back to you again, Dayang, on this question. There are two questions here, but I think they're interrelated, so I'm just going to group them together. So questions from Marza and also Buri Ray. Marza is sharing her observation. My father is 76 years old, had a previous minor stroke, but he was not diagnosed as dementia. Lately, my dad has started to become forgetful on and off. Sometimes he will pee on the bed, talk nonsense, and when he becomes lucid, he doesn't remember what just happened and becomes just a normal person again. So she's asking, is this an early sign of dementia? And this also kind of relates to a question by Buri Ray. What are the early signs of dementia in a person?
Okay, from the first person which is given a scenario of a father, right? He has had a mild stroke, and we need to know probably whether that stroke is due to hypertension or due to heart problems, whereby you've got clots in the blood, and it affects the brain structure and brain supply to certain areas of the brain. Diagnosing or looking into symptoms of dementia as well. Number one, you've got that history. I mean, I don't have the complete history that your father has. You've given quite a little bit. So this is just a general observation of mine from my experience being in the stroke unit way back when. Before we actually assess for dementia as well, because your father has had a stroke, all right, there may be a possibility that he has had a re-stroke. So going back to your neurologist or the physician in charge, the doctor in charge of your father's stroke condition, may well be important to guide you through as to whether he had a stroke, another stroke that has that dementia symptoms, or is he progressing into Alzheimer's or a progressive type of dementia. So the possible interventions or investigations that may come into play is they may want to do another brain scan on your father to see if the brain actually digresses due to another stroke, or maybe it's, progressive disease of Alzheimer's. And that's where the neurologist or the neurosurgeon can actually tell you, okay, your father has these symptoms because he actually has another stroke, or okay, it's most probably Alzheimer's. All right. Then when we have that brain scan, and when your doctors has seen what all the data, all the information that you have said, the incontinence, the forgetfulness, and things like that, how frequent it is, does it happen more at night, does it happen more in the daytime, does he recognize that? Those are all the different types of things that they may want to know. So when you go to your primary care physician with regards to his condition, make sure you bring the most important person who spends the most time with your father. It may be you, it may be another sibling, it may be your mother, who has had more exposure and has observed more things of the changes in your father itself. So the doctors, the primary care physicians will know and try to rule out whether it's another stroke, whether it's something metabolic due to his heart disease or any other conditions like, kidney disease, things like that, or maybe it is Alzheimer's. So yeah, to answer the second question, like I said, Alzheimer's, I'll just open my presentation again. There's a lot of different types of symptoms in Alzheimer's itself. But the main characteristics is whereby it affects the thinking processes in that person. So it may actually start out as simple forgetfulness. I mean, simple forgetfulness, even I forget where I put my keys, but it doesn't progress to a higher level forgetfulness in a short period of time and things like that. So simply put, whatever that is being used in your activities of daily living, all the thought processes that you use, trying to set the temperature on the shower, for example, so that it's not too hot or too cold, determining all this, trying to drive the car that you have driven for the last 20 years, trying to cook, all these things has different type of thought processes. And if these thought processes are affected up to the point that they're not able to do these activities anymore, the simple thing of, buttoning up a shirt, the button's all wrong, recognizing which way to the supermarket, which is the shortest way, which is the longest way, whether they get to the supermarket itself, going through all those, recipes, trying to make something and it comes out differently. If it's something that is not common to the person and it regresses and it gets worse and worse, then you may need to bring that person in for a total assessment on whether it's dementia or not, or whether we can rule out, dementia, maybe it's due to something else, because some cases like brain tumors may have all these symptoms as well. And we can only determine whether it's dementia or brain tumor when we bring someone into the healthcare facility to go through their symptoms, to go through their history, to go through what they have done, and to see whether the timeline fits the description of, is it brain tumor, brain cancer, or is it dementia? So these are the things that the healthcare professionals, the doctors, your physicians, your specialists will take into place. And this is why it's very important for the caregiver to know about a lot of things. And it's not very easy to be very observant in this case, especially for those who have just started to care for the older persons in their family.
Thank you, Diane. One last question coming your way. And this is a combination, I think, of 3 questions here from Kairu, Rose, as well as Natasha. Are there any certain medications, for example, sleeping pills, or even medications used during a general anesthesia, are they known to contribute to the development of dementia? And following that, are there any interventions known to slow down the progression of dementia?
Okay. When we talk about medication side effects, it also depends on the condition of the patient. When I talk about risk factors of those who are at a higher risk of dementia itself, things like sleeping pills, they can actually induce sleep apnea in certain persons because they really sedate the person. And especially if an older person has all this sedative medication and they do not know how to, titrate to adjust the dosage, it can cause some form of hypoxia to the brain due to sleep apnea. But if it's being addressed as quickly as possible, if the caregiver actually knows, they're snoring at night, they've got difficulty, they suddenly stop breathing, then they start breathing again, and things like that, it may be addressed and it may not actually contribute to the progression of dementia itself. Things like anesthesia. Anesthesia is not something you use every day. It's a once-off most of the time. You don't do anesthesia, you don't give anesthesia to, older persons especially as well. There has to be a risk assessment there from the anesthetist or the nurses and whoever is giving the anesthesia as well. A once-off is not very likely to cause dementia itself. In fact, we don't look into dementia as a big contributor to problems with anesthesia. Hypoxic brains are even more a bigger issue in this sense, because if the anesthesia is not being given properly, the ventilation is not being given properly, then you get a hypoxic brain. Then you get dementia-like symptoms due to the hypoxic brain and the brain injury that is caused by the cut off supply of oxygen to the brain. All right. So that's for medication. What was the next one again? I can't remember.
Are there any interventions to slow down the progression of dementia?
Oh, yeah. Okay. So when we look into dementia itself, like I said, if it's a progressive dementia, it's It's not reversible, but we can try to slow down the progress. And it's not something that is, you give a bit of medication, bam, that's it, you're sorted. No, because this involves the cognitive skills of the person. This involves the thinking skills of the person. Like when you teach your children how to memorize multiplications, you go routinely. You see, simple and routine and consistent. That's it. The thing with dementia, it's similar. When you keep certain familiar activities, consistent, routine, like, every Sunday go supermarket, things like that. She wants to go and buy her own food. Things like when you keep these things routine, when you keep the activities of daily living as routine as possible, as simple as possible, that caters to her needs, it helps with maintaining that strength of the thought processes itself. Because number one, they are less distressed, they are less stressed, they are less distressed, they are less disturbed with what is going on around them, they are less demotivated, they eat better. We know that nutrition is very important as well. They may sleep better in this sense because they're not emotionally affected by this. They can actually carry on a better way of living when we cater to their needs and early, and we keep them to be as independent and as early as possible. But it depends as well on which level of severity of the dementia that person is in as well. If you catch it in an early phase, it's actually easier work for the caregiver, because you're going to bring them out, you're going to bring them on trips, you're going to introduce music therapy if they've ever played music before and they like music. If they like line dancing, they don't have painfulness, why not? You see, that helps with reminiscence, remembering what has been done in the past, and that helps with thought processes as well. So when we look into prolonging the stability of the mind itself, in a sense, we've got to preserve that thought processes keeping it routine, keeping it simple, keeping it up to the limits of the patient or the person with dementia and the caregivers is very, very important.
Thank you, Dayang. I think that got the question right on the dot. So one last question for Mr. Tan. For interested parties, how can we contact Sarawak Gerontology and Geriatric Society, SGGS? You mentioned that there was a society website, and do you want to share your links out with the public?
Yes, we can be contacted through our letterhead, which of course not everybody have. We can be reached by Facebook,
right?
Social media, under the Sarawak Gerontology and Geriatric Society. Just drop a line. Drop a line, and then I will personally ensure that it will get the response required.
Okay, all right.
I would
Thanks,
say
Mr. Tan.
immediate response.
That's good. I did do a quick search online, and I did find the Facebook page for the SGGS. So for those of you who are interested in getting contact with the SGGS, please do a search on Facebook. On Facebook, look them up, Sarawak Gerontology and Geriatric Society. So thank you very much, Mr. Dennis. Thank you very much, Dayang. Ladies and gentlemen, to wrap up our session today, here are some key takeaways that I've put together from today's webinar. So here are some six key points that I gather from the presentations from both Mr. Tan as well as Dayang Zuraina. So first and foremost, dementia is an umbrella term for several diseases affecting memory, other cognitive abilities and behavior that interfere significantly with a person's ability to maintain their activities of daily living. And the prevalence of dementia will increase significantly in tandem with the growing elder population and cannot be further disregarded. Safety is also a paramount concern for individuals living with dementia and people caring for them, and it concerns everyone in the society. Dementia-friendly communities at the grassroots have the power to change the way people recognize, think, and feel about dementia to be better engaged with their overall care and safety. Fourthly, there is a need to recognize and acknowledge the exhaustive and integral role caregivers play in dementia to gain better support from the community and family unit, as well as the community support groups who should help to prevent caregiver burnout. The issue of stigma still persists, and people are afraid to be diagnosed with dementia and are reluctant to speak about their conditions. To alleviate such stigma, we can learn from successful past advocacy approaches, for example, like with cancer, autism, and also Down syndrome. Ultimately, solidarity among the government and other sectors, regions, generations, and even internal solidarity within organizations is critical in making activities concrete and operationalized with regards to dementia care. So with that 6 points, ladies and gentlemen, I think we have come to the end of our health talk series for this time around. Do tune in again for our next health talk, and you can get information on our upcoming health talks on our Faculty of Medicine and Health Sciences UNIMA's Facebook page. Ladies and gentlemen, for those of you who have attended the talk today, please do not forget the committee is going to put up a link to an evaluation or feedback form. We need you to fill up this feedback form, all right? And this will help us gather the information required from you to give you your certificate of attendance electronically, all right? So please ensure that you are careful filling up this feedback form. Make sure you enter the right email address and the right name or particulars that are required so that the electronic certificates can reach you in time. All right. So with that, ladies and gentlemen, on behalf of the Faculty of Medicine and Health Sciences, the university and the organizing committee for this health talk series, please allow me to express our sincere gratitude to both Madam Dayang Zuraina as well as Mr. Dennis Tan for their insightful sharing today. All right. So attendees, please stay back. do not forget to complete and submit the feedback forms using the link, which is going to be shared with you shortly. So thank you and see you in our next Health Talk series.
Thank you, Joel, and thank you, Diane.
Thank you, Mr. Dennis. Thank you, Dave, for everything. Thank you.
Thanks. See you guys.
See you.